So here, let's look at this example.
For trauma patients with isolated injury and no significant mechanism of injury, or responsive medical patients, focus on the body systems involved and the specific injury or illness guided by the patient's chief complaint.
Everybody all right? What's wrong?
I think I broke my ankle.
You hit your head or anything?
I don't know.
Determine the patient's level of consciousness using the patient's orientation to person, place, and time.
My ankle.
Your ankle?
Yeah.
Do you have any pain in your neck?
No.
Alright, we're going to put a collar on you because you're not sure if you hit your head or not. Alright. I'm going to put this neck collar on you and we're going to lay you back nice and easy so that way we don't end up hurting your neck at all, alright? You alright? Alright, sir, I'm going to take your vitals. Listen your ankle. Alright, let me see your wrist, please. Just take your pulse.
Obtain baseline vital signs. Assess the pulse rate, strength, and regularity. Assess respirations for rate, depth, and quality.
62. Just checking your respiratory.
Determine the blood pressure and assess skin temperature, condition, and color.
Alright, so I'm going to take your blood pressure now. Okay, do you have any past medical history? (116/80). Alright, so we're going to lay you back and do a detailed exam, alright? Alright, come on back, nice and easy. Take it there. Slow sounds now. Take down, I can get a better feel.
If indicated, perform a detailed physical examination.
Okay. So, before we get into doing the secondary assessment, we're going to get into, we have to determine the priority of patient for our care and transport. So high priority patients are patients that have difficulty breathing, serious mechanism of injury, poor general impression, unresponsive with no gag or cough reflex, and chest pain. Pale skin or other signs of poor perfusion, complicated childbirth, uncontrolled bleeding, responsive but unable to follow commands, severe pain in any area of the body, and an inability to move any part of the body. We're going to identify these as all high priority patients. Okay? Provide spinal immobilization if there's a possibility of spinal injury, or if you're unsure if the spinal injury is possible, we will then utilize our appropriate procedures for spinal immobilization. We have the golden period. This is the time from injury to definitive care. Definitive care, typically for trauma patients, is not at the hospital. It's on the surgeon's table with the surgeon cutting them open. That's definitive care. So that's what we are in, that's what we're going against, okay? Typically, golden period, we used to call it the golden hour. Now we really don't know what that time frame is. But all we do know is that we have about 10 minutes. That's our goal, is to get to the patient and off the scene and en route to the hospital in 10 minutes. So that means all this stuff I've been talking about for the last 2 hours, we got to be fast. We got to do it quick. Transport decisions should be made at this point based on the patient's condition, the availability of advanced care, distance of transport, and local protocols. So if ALS is on the way, and they're 5 minutes away and you've got 10 minutes worth of work to do, get to work. Get it done. And then when they get there, then you're able to get things done, turn care over, and then they can take over. If they are 20 minutes away, get them packaged, get them in the ambulance, and head towards them. Reconsider your mechanism of injury, because sometimes we can miss things. We need to make sure that we have a good plan and we know now more information about what part of the body, what organs could be affected, and now we kind of have an idea of what our patients are up against and what they might need. Like maybe a level 1 trauma center or a surgeon. Or maybe it's like the kid on the skateboard with just the fractured ankle. They need 2 totally different levels of care, right? Alright, so history taking. Whenever we're getting into a history, and let me go ahead and emphasize, you may not be able to get a history on all your patients, but you should always try. If you're going into an assessment station for testing, just because that patient is unresponsive doesn't mean you can skip that step. You need to try. And things you can do to get history is look for medical alert bracelets, look in their wallet for medical ID or medications. Women carry purses, they have medications in them all the time. Document the date of the incident, times of assessment. Make sure you put your times on everything and you keep up with the times you took your blood pressures and stuff. Write them down, it's important. The patient's age, sex, race, past medical history, and current health status. This is all information that we need to get. Investigate their chief complaint. Try to make the patient feel comfortable with you, because they need to trust you. Like we said earlier, don't stand over them, don't be intimidating. Ask a few simple open-ended questions and give them time to answer. And refer to the patient by their proper name and title. Like I said, not honey, hun, sweetie, or anything like that. If the patient is unresponsive, get clues from family members, medical alert, ID, or persons who may have witnessed the situation at hand. And we have the sample history, and we learned this already, right? Signs and symptoms, allergies, medications, past medical history, last role they've taken, events leading up to. We did this kind of before. And we can use the OPQRST unit to assess the pain. And let's watch this one.
In conscious medical In conscious medical patients, always obtain patient history before conducting a physical exam.
Hi, ma'am. My name is Mary. This is my partner, Brandon.
I'm just going to ask you a few questions here.
Follow the OPQRST approach.
For a start, what's wrong? What's pain?
I have a terrible migraine headache.
Okay. About how long ago did you say this started?
About an hour ago.
Alright. Does anything help with the pain? Sitting down, standing up?
No, not really.
Anything makes it worse?
No.
Okay. Can you describe the pain for me? Is it like sharp, stabbing, throbbing?
It's throbbing.
Throbbing? Okay. Is it radiating anywhere?
Yes, it's radiating across my forehead and down my neck.
Okay. On a scale of 1 to 10, what would you rate it?
I would say a 5.
Yeah, 0 to 10.
About how long ago was this?
About an hour ago.
Gather the sample history from the patient or from family or bystanders if necessary.
Okay. Do you have any allergies or medications or anything that you know of?
No.
Okay. Do you take any medication?
No.
Okay. Have you ever been to the hospital before?
Yes,
Okay, what for?
chopper,
What was the last thing you had to get pain
a salad.
You said you're teaching class temporary stuff right? Okay, so just gonna finish your photos here and then we're gonna get chocolate.
Okay.
From the information gathered, determine the patient's medical problem and provide appropriate interventions.
The one thing that I want to emphasize that they pointed out here is if you have a conscious medical patient, they're conscious. Your top priority at that point should be getting the sample history, patient history, OPQRST and stuff, because they could become unresponsive. And then you would have missed out on that opportunity to get that information. Alright, so we're going to get the OPQRST and we're going to document what we find, or any pertinent negatives, which goes, like if you're asking them for pain, if they have pain, let's say they say I have no pain, we'll document that. If their quality of pain, is it like a focal pain, like to one point, can you point to it with one finger? Or is it like pain that's just all over? Or is it a radiating pain that radiates around? Now, sometimes you're going to have some sensitive topics, especially like if your patient was the cause of this and maybe somebody died, and your patient was under the influence of alcohol. So it could be a little difficult for you and the patient to talk about it. However, we are professional, right? We have to rise above that and be professional about it. You don't want to be demeaning or rude or anything like that. You want to be compassionate, caring, and kind still, regardless, okay? So, some sensitive topics could be alcohol and drugs. Some of the signs could be confusing, hidden, or disguised because of the alcohol or drugs. Like, for instance, pain. Will alcohol blunt pain? Yeah. So this patient could have been in an accident, and right now they don't feel pain, but in reality they have injuries that would normally be causing pain that we could be missing. Physical abuse or violence, now I'm telling you, if I come in and this big old guy's right there, I'm calling PD, right? I'm not getting involved in that. With, just let me go ahead and throw this out here. The domestic abuse stuff, you do not want to get involved with. Don't even go there. Because it'll go from these two being mad at each other to both of these ganging up on you. It turns that fast. It can. Just back out, get PD involved, okay? You want to report all physical abuse or domestic violence to the appropriate authorities. Follow your protocol. Wherever you work at, there will be a policy for you to follow. Do not accuse on anything, okay? You want to document what you saw, the facts, nothing else, no opinions, nothing at all, just what you saw. If somebody tells you something, you can put that in there, but put it in quotation marks and make sure you know and put who said it, okay? And let the appropriate authorities do the investigation, not us.